Okay, so talking about chest and abdominal injuries. So we have hemothorax tension, pneumothorax similarities, tachypnea, dyspnea, cyanosis, diminished or decreased breath sounds, tracheal deviation, late sign, and asymmetrical chest rise. So let's talk about tachypnea. It's going to be quick breathing, dyspnea, not breathing, cyanosis. There's a lack of cyanosis. Yeah, so the body's not getting oxygen, which means that the skin is getting a blue hue to it because you're red because of oxygen that's in the blood. When you turn blue, you're no longer oxygenating, and that's also why you see blue dead people. Diminished or decreased breath sounds. Yep, you're not hearing them breathe. Tracheal deviation. So this is your trachea right here. If the lung is offset because they're not equilateral, it's going to be offset to the side that you have air not entering in the lung, but the sac around the lung is ballooning, pushing it to one particular side. So you have asymmetrical chest rise at that point as well. Hemothorax, tension pneumothorax differences. So with a hemothorax, hemo meaning blood, thorax, thoracic cavity, there's an accumulation of blood in the pleural space. The pleural space is the lining between the lung and the sac that is holding the lung. Maybe 2 to 3 liters, could be that massive. Dullness on percussion, hyporesonance. Hypo meaning nothing or not there, resonance like a drum. Imagine filling up a snare drum with water and tapping it. You're not going to get a loud noise. You're going to get hyporesonance. Narrow pulse pressure. So there is going to be a very, very narrowing pulse pressure between narrowing pulse pressure. We'll come back to that. Hypotension and hypovolemia. So hypo, again, meaning not there. You're going to have volemia, blood volume. There is a low level of blood happening in the body. It's going to be no JVD, jugular vein distension. And if we have tension pneumothorax, there's going to be an accumulation of air in the pleural space. You'll also have JVD, hyperresonance on percussion. So now, instead of there being blood in the snare drum, now there's air in it. It's blown up like a balloon. Imagine tapping an exercise ball, right? You flick it and you hear it hyperresonate on percussion. Subcutaneous emphysema. So there is going to be subcutaneous in the skin, so not where the muscle is, but in around the skin, kind of between the muscle and the skin. And emphysema, it's going to be almost like crackles, like bubble wrap that it feels like is popping. Patient will become hypotensive in late stages and obstructive shock. Yeah, so obstructive shock means something is blocking instead of hypovolemic shock. So what we would do to treat this is a needle decompression. We would take a 10 to 16 gauge needle, at least 3¼ length, and insert that needle above the rib to avoid the nerves. In vasculature, we don't want to stab the veins that are in the under the rib. Historically, second intercostal space, mid-clavicular. Updated evidence, fifth intercostal space, anterior axillary. So if we're going fifth intercostal space, this is a rib, this is a rib, this is a rib, this is a rib. We want to be about here. And then mid-axillary, not mid-clavicular. This would be mid-clavicular. Mid-axillary is more on the side, almost going in on the side right there. Anterior axillary. So one good way to tell is if you put the person, whoever they are, your hand underneath their armpit, typically where your pinky's going to be at, that's going to be fifth intercostal space, and you want to stick the needle just above the sixth rib right there, just above it. Intercostal space, yeah. So you're going to shove that in there, and you're going to hear a whistling sound of air coming out, or you're going to have blood spurt out if it's a hemothorax. Flail chest, 2 or more adjacent ribs are fractured in 2 or more places. So signs and symptoms of this, you're going to have bruising, tenderness, crepitus, and paradoxical motion with inspiration and expiration, which is a late sign. So bruising, because that's probably what caused it. There was some blunt force trauma. Tenderness, just like tenderizing chicken breast. If you beat it right, it's very tender. Crepitus, so that's more of that you feel the bones and like crackling, not the emphysema, the bubble pop. Paradoxical motion with inspiration and expiration. So as you breathe in, my chest goes out. Well, one chest is going to go inward and the other one's going to do the opposite. Treatment, SpO2 and ET carbon dioxide monitoring. We're going to assist in ventilations to achieve SpO2 over 94%. So we're going to create a positive pressure system that's going to push, even though the chest wants to breathe the opposite direction, we're going to push it to go the other way. Consider CPAP, because that does the same thing, continuous positive airway pressure. Consider intubation as needed. If they're not breathing, we're going to end up taking their airway if they go unconscious. Traumatic asphyxia. So severe crushing injury to the chest and abdomen results in increased intrathoracic pressure. So intra, not meaning inter, it's going to be around the outside thoracic pressure. So yeah, something crushes a heavy weight, maybe a barbell, forces blood from the right side of the heart to the upper thorax, neck, and face. Face will have a purple and red appearance. So management, we're going to want to use our ABCs in hypovolemic shock management. Hypovolemic, meaning there's not a high volume of blood in them anymore. And of course, BLS, ABC. Komodo cordis. This is what happened to the football player we saw recently. Leading cause of death in youth baseball, about 2 to 3 deaths per year. If there's blunt chest trauma timed during the upstroke of the T wave relative to the refractory period R on T phenomenon, which induces a ventricular fibrillation. So, I'm going to try to do this backwards. You have the P wave, the atrial loading of electricity that fires first into the atria, and then you have what everyone recognizes, the QRS wave, and then whenever it recharges the electricity, that's the T wave. So between that T wave and that R wave, QR on T phenomenon, if something strikes it and throws it off in the middle of that beat, that wave, then you're going to get Komodo cordis. Chest and abdominal trauma. So diaphragmatic rupture. Sudden compression of the abdomen results in increasing abdominal pressure. Signs and symptoms, we have abdominal pain, shortness of breath, decreased breath sounds, bowel sounds heard over the thorax. So management of this, we're going to have oxygen, ventilatory support, fluids, and rapid transports. With cardiac tamponade, we want to see cardiac tamponade in chapter 4, cardiology. Okay, evisceration. I feel like that just brazed over that. So evisceration, protrusion of internal organs or the peritoneal contents of a wound. Management, this would be if someone's intestines fell out. So they're not dead yet. Honestly, there's like a high chance that they could survive, but that doesn't mean you're not going to take those and shove it back in there like a bunch of hot dogs thrown together. You're just going to take it as one clump, put it on their abdomen, and strap it with abdominal dressing. Also making sure that it's moist, so you're going to moisten it and strap it to keep as much tissue from dying as possible and also keep infection from happening as much as you can. So cover the eviscerated contents with moist sterile dressing. Cover the moist sterile dressing with dry dress to conserve organ temperature. Never shove them back in there. So if we have a solid organ injury, we want rapid and significant blood. There's going to be rapid and significant blood loss. Solid organs most injured is either the liver and the spleen. Both can be life-threatening. If it's liver, the largest organ in the abdominal cavity, often injured by trauma to the 8th and 12th ribs on the right side. So second most commonly injured intra-abdominal organ, your mortality rate is going to be 54% if it's the liver. Shot to the liver, pretty much dead. Spleen, same, because that's where most of your blood is stored. Left upper quadrant, 40% of the patients have no symptoms immediately, but they're going to feel pain in their left shoulder. So this means Kerr's sign. This is referred pain. They'll feel it here, even if the liver is in the left upper quadrant way down here, or the spleen. Hollow organ injury. Sepsis, wound infection, abscess formation, spillage of the contents is primary concern, stomach being one of them because it's carrying acid, not often injured by blunt trauma. Colon and large intestines are more likely to be injured by penetrating trauma than blunt trauma. Abdominal trauma treatment, stabilize the patient, rapid transport, oxygen, permissive hypotension, 80 to 90 millimeters Hg, and we're going to check for other injuries. Reassess every 5 minutes. Going into fractures, so we have ligaments. Ligaments connect bone to bone. Tendons connect muscle to bone. Sprain, stretching or tearing of the ligaments, and strain is overstretching or overexertion of a muscle. I did one of these to my pet. I think it was strain. Blood loss associated with fractures. So if you crack the rib, you could lose 125 milliliters of blood. If you crack the radius or the ulna, 250 to 500 milliliters. That's just in your radius in the ulna. Humerus, so that's 500 and 750 milliliters. Tibia and fibia. It's like your humerus and ulna, but on your feet. On your legs, 500 to 1,000 milliliters. Femur, you could lose up to 2,000 milliliters of blood. That's a lot of blood. These are your types of fractures. So there's a transverse. Imagine a sword just chopping through that. Oblique, imagine it being done at an angle. Spiral, imagine twisting like Indian sunburn to two different sides. You can get a spiral break. Commutated, if it breaks in multiple places. Segmental, if it's somehow very evenly broken. I don't know what would do that, but segmental. Impacted, so let's say that it is shoved into itself if you fell from 3 stories. Impacted. Torus, really don't even know if that's just hereditable, inherited, or if it's been smushed. Green stick, typically what's going to happen, mostly with children, because they're pliable bones. Green stick, yep. I don't know what torus is. Injury presentation, so we have hip fracture. Affected leg is shortened and externally rotated. Fractures that are closer to the head of the femur may present similarly to anterior hip dislocation. Shortened leg and internally rotated. Hip dislocation, affected leg is shortened and internally rotated. Usually a posterior dislocation of the femoral head. Femur fracture, affected leg is shortened and externally rotated with a mid-thigh swelling from the hemorrhage. We'll stop there.